Hey everyone, and welcome to The Explainer. I am so excited you're here. Today, we are taking on a massive and honestly absolutely fascinating topic. We are going to decode the complex, sometimes totally overwhelming, alphabet soup of modern medical neuroimaging. From CTs to MRIs to PET scans, we're going to break down exactly how we look inside the human brain. Picture this. A patient is rushed into the emergency room with a suspected stroke. Time is quite literally brain tissue. Every single second counts, so how does a clinician instantly know whether to throw that patient into a scanner that rapidly spins x-rays or carefully slide them into a giant 3 Tesla magnet? These are real-world, incredibly high-stakes decisions, and by the end of this explainer, you're going to know exactly how those choices are made. All right, here's our game plan for today's modality masterclass. We'll run through the neuroimaging arsenal, hit CT speed and precision, explore MRI as our detailed detective, cover crucial safety protocols, dive into functional imaging and PET, and wrap it all up with interventional neuroradiology. Let's get right into it. Section 1. The Neuroimaging Arsenal. Choosing the right tool for the job.
Okay, so picking between a CT and an MRI is really all about choosing the right tool for the job. Just look at this breakdown. Acute trauma or an acute subarachnoid hemorrhage, you definitely want a CT or a CTA. That's CT angiography. It's incredibly fast and just amazing for viewing bone and fresh blood. But what if we're dealing with an ischemic infarction or a demyelinating disease like multiple sclerosis? For those, MRI is your undisputed champion. Simply put, CT is for speed and bone. MRI is your absolute master of soft tissue detail.
Moving on to Section 2. CT. Speed and precision. From fast scans to microscopic resolution. Notice the sheer technological leap we're looking at right here. This is not your grandfather's CT scanner, this is a photon-counting CT. Instead of converting X-rays to light and then trying to turn that into a signal, the detectors convert X-rays directly into electrical signals. It brilliantly illustrates this massive upgrade in technology. We're revealing a tiny 0.2 millimeter autosclerosis lesion in the temporal bone. It is mind-blowing resolution and often at a reduced radiation dose too. And, speaking of radiation, let's demystify that for a second. A routine brain CT exposes a patient to about 2 to 5 millisieverts of radiation. While we obviously always want to keep doses as low as possible, let's put that into perspective. It's highly comparable to the everyday background radiation you get just living on planet Earth, flying in jet planes, or even just being around household smoke detectors. All right, Section 3, MRI, the detailed detective, interrogating the protons in your brain. So the physics of MRI can honestly seem like pure sci-fi magic, but we can easily break it down into 4 logical steps. Step 1, we hit the body with a specific radiofrequency pulse. Step 2, that pulse excites the hydrogen protons in your body's water and fat molecules. Step 3, we turn the pulse off and those protons relax back down to their normal state, releasing energy as a sort of echo. Step 4, coils pick up that echo and a computer generates an incredibly detailed image. We are literally manipulating hydrogen to take a picture. How cool is that? Now, by tweaking the timing of that echo, we can create different weights or filters. T1-weighted images have a short echo time. They act like a filter for fat, making it look bright white, while water shows up dark. T2 uses a longer echo time, making water and edema glow brightly. And FLAIR? Well, FLAIR is just genius. It takes a T2 image but specifically suppresses the bright signal of normal cerebrospinal fluid, so pathological water, like a tumor or brain swelling, stands out completely unobstructed. Okay, now we are entering the real alphabet soup, DWI and ADC. Diffusion-weighted imaging tracks the tiny microscopic motion of water molecules inside your brain. Apparent diffusion coefficient is the quantitative map of that restricted motion. Why should you care? Because if brain tissue dies, water gets trapped inside the swelling cells. This makes DWI and ADC the absolute gold standard for detecting an acute ischemic stroke that's under 7 days old. Notice how this plays out visually. You can see a bright white spot in the pons on the DWI scan. That's the restricted water. Now look at how it correlates to a dark spot on the ADC map. This specific combination visually proves an acute stroke diagnosis within mere minutes to hours of it actually happening. It's an absolute game changer for patient treatment. Next up is SWI, or susceptibility weighted imaging. Think of this one as the MRI's built-in metal detector. It is incredibly sensitive to alterations in the local magnetic field. We use SWI specifically to hunt down tiny microhemorrhages, those little deposits of blood that are associated with conditions like chronic hypertension or amyloid angiopathy.
Let's look at the brain's plumbing for a second. MRA, or magnetic resonance angiography, gives us a macro view of the blood vessels, but VWI, or vessel wall imaging, uses high spatial resolution to look at the actual physical wall of the artery, which lets us spot inflammation like vasculitis. And then there's ASL, arterial spin labeling. ASL is amazing because it lets us measure cerebral blood flow by magnetically tagging the blood in the neck right before it enters the brain. It's completely non-invasive, with zero IV contrast required.
Rounding out our structural MRI acronyms are MRN and DTI. MR neurography is designed to light up inflamed or damaged peripheral nerves outside the brain. Meanwhile, diffusion tensor imaging maps the complex, beautiful architecture of the white matter tracts inside the brain. It acts as a literal, colorful roadmap for neurosurgeons, allowing them to plan tumor removals without accidentally cutting critical connections for speech or movement.
Section 4. Safety and Contraindications. Crucial protocols for patient protection.
So a super crucial point here is knowing what can and definitely cannot go into an MRI scanner. You probably already know about pacemakers, but check out this list of surprising contraindications. Cochlear implants, bone growth stimulators, even certain old aneurysm clips. But look at that bottom one, tattooed eyeliner. Yeah, some of these pigments contain ferromagnetic material that can actually heat up and irritate the eyes inside the powerful magnetic field of an MRI scanner.
And when it comes to the chemical contrast agents we sometimes inject, I want to strongly emphasize this critical protocol. If a patient has a known allergy to iodinated contrast, trying to rush a pre-medication regimen with steroids or antihistamines in less than 4 to 5 hours is completely ineffective. Whether it's oral or IV, short-duration regimens just do not work, and cutting corners here puts the patient at severe risk.
Moving to Section 5, Functional Imaging and PET, Mapping Brain Metabolism and Activity.
Functional MRI, or fMRI, tracks tiny changes in blood oxygenation. When a part of your brain works harder, it needs more oxygen, and fMRI maps that right in real time. PET scans, on the other hand, use radioisotopes like FDG to map glucose uptake. Remember, the brain runs on sugar. If we see parietal lobe hypometabolism, which basically means that area of the brain isn't eating enough sugar, it's a massive clinical clue that helps us diagnose things like Alzheimer's disease.
And finally, Section 6. Interventional Neuroradiology. From passive imaging to active healing.
Using continuous real-time imaging, specialists can now thread catheters through the vascular system all the way up into the brain. We aren't just taking pictures anymore. We are actively deploying detachable platinum coils to pack and seal off bleeding aneurysms. We're using stent retrievers to physically grab and pull stroke-causing clots right out of the brain. Honestly, we are changing catastrophic patient outcomes into miraculous recoveries on a daily basis.
Which brings us to our conclusion, and a thought I really want to leave you with today. We've gone from simply trying to get a blurry picture of the brain's anatomy to actively guiding its healing from the inside, in real time on a microscopic level. As these magnetic fields and photon counters get even more incredibly precise, what future limits of the human mind will image-guided interventions unlock next? Thank you so much for exploring the alphabet soup of neuroimaging with me today. Keep learning, keep questioning, and I'll see you in the next explainer.